Gotcha. All right. I'll give. All right, so it is 8 Central Standard Time, so I'm just going to go ahead and get started with these questions. So, per the requests of the group that was with me last week, they wanted to go over musculoskeletal interventions and they wanted to go over neuro interventions. And so, that's what we're going over today. So, questions 1 and 11. Questions 1 and 11 I actually posted as videos this week just to give some practice questions throughout the week. So I'm going to skip questions 1 and 11. If you guys want to do those questions, then by all means go back and watch the videos where I did questions 1 and questions 11. So today I've only got 18 questions for you guys, but the first 9 are going to be musculoskeletal intervention questions, and then the second 9 are going to be neuro intervention questions. So I will go. I'm trying to shorten my talking down and my explanation, so I've tried to more succinctly summarize why things are right and why things are wrong at the bottom of each question. I'll give extended time at the end of each question after we've gone through why the stuff is right and why the stuff is wrong, so that you guys can take notes if you want to. Feel free to take screenshots. I don't even know if you can take screenshots on live, but if you can, I don't care if you do that. I haven't charged my mic in a bit, so if I suddenly just die, like if my mic suddenly dies, just let me know, and I'll just take it all off and unplug it, and I'll just talk through the camera mic. So let's go ahead and start with number 2. If you guys are just joining, we're starting with number 2 because number 1 I did a video on separately this week, and number 11 I also did a video on separately this week. So I'm just going to start at number 2, and then we're going to skip number 11. Okay. So number 2, a patient with adhesive capsulitis freezing phase presents with severe pain and progressive range of motion loss. Which intervention is most appropriate? A, high-grade joint mobilizations into end range. B, sustained stretching into capsular restriction. C, aggressive strengthening of rotator cuff muscles. Or D, gentle, pain-free active range of motion and pendulum exercises. If you guys will, just to build up the interaction on the live so that way you guys can see everyone's thought processes, please go ahead and submit what you think the answer is, and then after a minute or so of you guys submitting answers, I'll go ahead and tell you what the right answer is and why the wrong answers are wrong. Okay, so take your time, and let me reread the question while you guys are thinking. So a patient with adhesive capsulitis freezing phase presents with severe pain and progressive range of motion loss. Which intervention is most appropriate? A, high-grade joint mobilizations into end range. B, sustained stretching into capsular restriction. C, aggressive strengthening of rotator cuff muscles. Or D, gentle, pain-free active range of motion and pendulum exercises. So several of you have submitted your answers. I'm going to give about another 30 seconds so that everyone else can submit their answers if they'd like. So something crazy that happened today. So I live in Northwest Arkansas, and I went disc golfing at 1, and it was 70 degrees at 1 o'clock. And now it's below freezing. So it's been 6 hours, and we went from 70 degrees to below freezing. So that's pretty wild. Okay, so the answer is, like you guys said, D. Let's go over why. So in the freezing phase, your main restriction, or the thing that's going to restrict range of motion, is going to be pain, right? It's not capsular restriction yet. It's not other soft tissue restrictions. It's pain. So you want to prioritize symptom modulation and gentle motion just to keep the muscles active, but they're probably not going to tolerate strengthening yet. So if we look at A and B as answer choices, high grade or sustained stretching will increase inflammation, especially because look at what A and B say, into capsular restriction and into end range. So if pain is your major range of motion limiter and you're pushing them into capsular restriction, you have already pushed them into tremendous pain. And so they're going to be super pissed off at you, number 1. But number 2, you're going to be stirring up inflammation because you're pushing them into great pain. Same thing with A. C, strengthening isn't going to be tolerated, especially if anything says aggressive strengthening, and we're talking about the early phases of a condition, then aggressive anything is probably not a good idea. If we're in more of like the chronic phases of stuff, then yeah, it might be a better idea to do aggressive strengthening. But okay, so that is why D is the right answer. If there are any questions, feel free to submit them as we go along, but I'm just going to keep on cruising through until you guys have a question for me, okay? Okay. All right. A patient with cervical radiculopathy at C6 reports decreased arm pain with cervical distraction. Which intervention best supports symptom centralization? A, repeated cervical extension exercises. B, mechanical cervical traction. C, thoracic spine mobilization. Or D, upper trapezius strengthening. Go ahead and submit your answers. I'm going to reread it one more time a little bit more slowly. A patient with cervical radiculopathy, C6, reports decreased arm pain and with cervical distraction. Which intervention best supports symptom centralization? A, repeated cervical extension exercises. B, mechanical cervical traction. C, thoracic spine mobilization. Or D, upper trapezius strengthening. Go ahead and submit your answers. Just going to be looking through to make sure. Okay. All right. Give you like another 30 seconds to answer if you'd like to. And like, don't be afraid to answer. If you get it wrong, it's not that big of a deal, because one thing that we know about learning and the science behind learning is that actually interacting with material is what makes it stick in your brain. So whether you answer it and get it right or answer it and get it wrong, it's going to stick in your brain better because you interacted with the material. And then I'm going to go over why the right answer is right and why the wrong answer is wrong. And so if you get it right or you get it wrong and you stick around for the explanations, your brain is going to better remember the material. So let's go ahead and talk about which answer is correct. So the answer is B, mechanical cervical traction. So distraction, relieving symptoms, suggests foraminal compression, traction promotes decompression and centralization. Okay. A, extension may help later, but traction in the earlier stages is going to be more specific. C, thoracic mobility is helpful in the long run, but it's indirect in improving centralization of pain, especially from cervical spine. And then D, strengthening doesn't reduce nerve root compression. So that's why D is wrong. So that's why B is the right answer. I'm just going to keep on going through, but if you guys have questions as we go, just type them in and I'll stop and I'll address the question, okay? So let's move on to number 4. Following a rotator cuff repair 4 weeks post-op, which intervention is most appropriate? A, active shoulder abduction against gravity. B, passive range of motion within surgeon guidelines. C, closed chain weight bearing through the upper extremity. Or D, resisted external rotation with bands. So, go ahead and submit your answers. Explanation rationales are great. Thanks, Trent. I tried to be a little bit more succinct because last week I was worried that I was being way too wordy. And this way, if I put them on the sheet and you guys are taking notes or whatever, or you want a screenshot with the explanations, I actually have them here. And so, yeah, feel free to take these down as notes or whatever you guys need. Okay. All right. Several of you have gotten the chance to answer, so let's go ahead and go over it. At 4 weeks post-repair, the tissue healing still dictates protective passive motion only. So, everyone that said B, you are absolutely correct. 4 weeks is still super early post-op. We don't want to risk re-tearing anything, and A and D are both going to risk re-tears this early on in recovery. And the reason C is wrong is just because closed chain weight bearing is premature, especially putting force through that joint in closed chain, and you're having all of those muscles have to stabilize isometrically when you wait there, and so that could also risk re-tear. So, trying to be a lot more succinct. My hope is that if I'm more succinct in explaining the answers too, I can actually get through more questions more quickly and maybe save some more time at the end for any questions or tips or whatever. And if we're getting through really, really quickly, then I can just add more questions in the future. Okay, number 5. Let me scroll down, try not to reveal the answer. A patient with mechanical neck pain demonstrates reduced thoracic extension mobility. Which intervention best addresses contributing impairments? A. Cervical isometric strengthening. B. Thoracic spine mobilization. C. Soft tissue massage to cervical paraspinals. Or D. Cervical traction. A patient with mechanical neck pain demonstrates reduced thoracic extension mobility. Which intervention best addresses contributing impairments? A. Cervical isometric strengthening. B. Thoracic spine mobilization. C. Soft tissue massage to cervical paraspinals. Or D. Cervical traction. Let you guys take time to answer. Okay, give you guys like another 30 seconds to think about it and submit your answers. Don't be afraid to submit. Like I've said in the past, the more you interact with the material, the more your brain will retain it, even if you get it wrong, because we're going to go over the right answers and why the wrong answers are wrong. Speaking of that, what is the best way you guys seem to learn? Do you guys feel like could you make it a little bigger, please? Yeah, 100%. 100%. Hopefully I can fit a whole question. Yeah, perfect. Thank you, Trent, for the recommendation. If you guys need anything, yeah, of course, dude. If you guys need anything from me to make this actually helpful, just submit it in the chat. The whole purpose I'm doing, I don't make money off of doing lives. I just do this for my fun, but also your guys' benefit if it's helpful for you. So, I don't even remember what I was saying anymore. Oh yeah. What do you think is the best way that you guys learn? Are you more visual learners? Are you more kinesthetic learners, like actually writing things out? Are you auditory learners? Because if you guys end up kinesthetic learners, Skylar, cool. I'm not a big kinesthetic learner. I studied with a group of 3 other guys in my PT program, and a couple of them were super kinesthetic. So we would utilize the whiteboards. And even though I'm not a very kinesthetic learner, there's really good research that supports just writing things down helps things stick better in your brain compared to like typing them out. And so I would write things down on the board, and then after we got everything written down, we would turn around and teach it all to one another. So like I would take a specific topic, let's say like Parkinson's disease treatment or something, and each of my buddies would have a different topic. And as soon as we all got done, I would turn around and I would teach them everything I had written on my board. They could ask me questions, they could add to it if I had missed stuff, and then it was talking it out and then hearing them teach it to me that actually helped things stick for me. Kinesthesia doesn't seem to be, or kinesthetics doesn't seem to be super helpful for me, but I know that it is, like research shows that it sticks in your brain better. Mixed between kinesthetic and collaborative social, yeah, talking it out is dope. I write it down and read it out loud. Yeah, and honestly, part of that reading it out, I've also given people tips on like, if you have an area that you're struggling with, like make videos of you having to teach it. So even if you're not ever sharing that with anyone, if you just like prop your phone up and take a video on your own camera of yourself having to teach it, if you can teach it, you definitely are, it's sticking a lot better. It's getting encoded a lot better. And so that was always helpful for me too. Okay, talked for long enough. Let me jump into the answer choices. So the answer is B, thoracic spine mobilization. So thoracic hypomobility increases cervical loading and contributes to neck pain. So addressing that thoracic spine mobility is going to help decrease cervical loading and thus decrease the neck pain. Isometrics are not going to address thoracic joint restrictions. Soft tissue massage, especially to the cervical paraspinals, but even if it was thoracic paraspinals, soft tissue massage is not going to help improve the joint mobility, and cervical traction isn't going to reach low enough into the thoracic spine to really help mobilize anything. So that is why the answer is B. One thing that's super important anytime you guys are studying for anything, but particularly obviously the most important test of your life. Even more, I would say the NPTE is even more important than any specialty exam. Like I took my NCS, and the NCS was the hardest test I've ever taken, way harder than my boards. But I would still say my NPTE was the most important test I ever took because even if I didn't pass my NCS, I was still a practicing physical therapist. And so, when you're studying for the most important test of your life, make sure that you are doing it the way that you already know how you learn. I know that sounds super dumb, but would you prioritize grade 1 to 2 for the mechanical pain? That's a great question. They have mechanical neck pain, right? So it doesn't say where in the neck it is, but the presumption is that it's somewhere in the cervical spine, not necessarily the cervical thoracic junction. But Trent, that's a good question. Um, you could definitely prioritize some grade 1 to 2 in the cervical spine just to help address that pain modulation. But ultimately, if you are suspicious that it's like clinically speaking, yes, that could be helpful. But in terms of this question, obviously, that's not an option, right? Number one. But number two, if the question is setting you up that you're like such that your suspicions are the thoracic hypomobility is causing the issue, then yeah, you should probably make sure that you're doing realistically probably grade 3, grade 4 thoracic mobilizations. But you don't even have to know that much. You just got to know the thoracic spine, the questions, or the stem says the thoracic spine is the issue. How are we going to help improve that? So, but yeah, that's a solid question, Trent. Clinically, I probably would uh, address both ultimately, because if they have cervical pain, then we know that those grade 1 and grade 2 mobilizations can help modulate that pain response. So, good question. Austin Gordillo says, can we do non-systems research exam questions next? Yeah, for sure. I did some last week. I'll probably do half of them as non-systems or research questions. But then the other half, I may pick stuff that we haven't done yet is like other systems, so like our lymphatics. Oh my gosh, skin. I don't know why I can't think. Integumentary. Is the answer B? Yes, girl. The answer is B. Good job. And this is the explanation why, Lee. So yeah, I can do some non-systems, and then I might do some other system stuff too because we haven't gotten to that yet in these NPTE night school sessions yet. Okay, let's go on to number 6. I'm talking a lot. You guys got to shut me up. I won't be offended if you tell me, hey, we've only got so much time on a Sunday night. Okay, number 6. A patient presents with scapular dyskinesis and shoulder pain during elevation. Which intervention is most appropriate? A. Upper trapezius strengthening only. B. Passive shoulder range of motion to end range. C. Serratus anterior and lower trapezius strengthening. Or D. Glenohumeral joint mobilizations alone. Oh, wait, actually, never mind pharmacology. Okay, no big deal. I'll get some stuff together for you guys. Okay, give you guys a little bit more time. Okay, so let's just remember scapular dyskinesis. What's happening here is you aren't getting adequate firing of your force pairs or your force couples. And so you may have one muscle in your force couples or force groups, I guess if you could call it, because really it's more than just 2 muscles that are helping with upward scapular rotation. And so obviously, if you're getting shoulder pain during elevation, you're probably not getting adequate upward rotation of the scapula, and so you're getting impingement underneath that acromion because you're not getting adequate scapular rotation, right? And so, in most cases, let's go ahead and look at the answer. So, like I said, scapular dyskinesis is impaired force couples. You need to restore scapular control. So, if you're looking at A, that's not going to improve the motor control and coordination between your force couples because you're not asking the synergists to work with upper trapezius. You're just strengthening upper trapezius. And in most cases, upper trapezius is already going to be overactive. B, range of motion without control won't fix movement dysfunction. This goes back to your motor learning classes, right? And D, glenohumeral joint mobilizations won't address the scapula. So really, like I was saying, if you don't have enough scapular upward rotation, then it's like you may be thinking, oh, well, the structures are getting pinched underneath the acromion. If they already have like sufficient capsular mobility, then doing more mobilizations or isn't going to help the pain. It's just going to maybe make them even more lax. Worst case scenario, best case scenario, it's going to do nothing for them. And so you really want to make sure that you're strengthening the synergists that help do that upward rotation movement. And so that's going to be your serratus anterior and lower trapezius. So let's move on to number 7. This is stuff that I deal with all the time, but not just cervicogenic headaches. I deal a lot with cervicogenic dizziness as a neuro and vestibular therapist. So number 7, a patient with cervicogenic headache demonstrates limited upper cervical mobility. Which intervention is most appropriate? A, deep neck flexor strengthening. B, upper cervical joint mobilizations. C, vestibular habituation exercises. Or D, mechanical lumbar traction. Let me read it one more time. A patient with cervicogenic headache demonstrates limited upper cervical mobility. Which intervention is most appropriate? A, deep neck flexor strengthening. B, upper cervical joint mobilization. C, vestibular habituation exercises. Or D, mechanical lumbar traction. If any of you say D, I'm going to laugh out loud. All right, give you guys a little bit more time to answer. Actually, let me look through. Several of you already answered, so we'll just go ahead and talk about it. I was just kidding about laughing out loud, but if you say D, I'm really gonna have to go over why that wouldn't be helpful at all. Okay, so cervicogenic headaches often arise from your C0 to C3 dysfunctions, and so we know that it's going to have something to do with your upper cervical spine. So A would be helpful, especially in the long run, but it's going to be secondary because strengthening your deep neck flexors, which is going to be lower anterior cervical spine, isn't going to help the dysfunction that's happening in the upper cervical spine, right? C, vestibular habituation exercises. It's not a vestibular issue. It's a musculoskeletal issue arising from the upper cervical spine. So if you have them do vestibular habituation exercises, you're treating the wrong system and it's not going to be helpful at all. And D, lumbar traction is totally irrelevant because their pain and their headaches are happening in their head, not in their low back. So that one was super easy, I hope. It seems like it was. You guys all got it right. Number 8, a patient with postural, sorry, that was a bad mistype. A patient with postural neck pain works at a desk 10 hours a day. Which intervention best addresses long-term symptom management? I'm going to fix this because that's going to bother me. Okay, a patient with postural neck pain works at a desk 10 hours a day. Which intervention best addresses long-term symptom management? A, manual therapy at each visit only. B, cervical collar during work hours. C, daily cervical traction. Or D, postural education and ergonomic modifications. Many of you are answering. Very good. Thank you for interacting with the content. You're good, babe. I'm telling you, hey, user 15432789. You answered 3 times. I appreciate your interaction. I have not forgotten about you, though. I will message you after this so we can talk about that practice test score that you sent me and the stats on it. And then we could talk about trying to, what I think would be best to strategize in terms of where you should focus your studies for the next week, roughly. Okay, so I don't know user 15432789. I just am putting that out for any of you guys. If you are having a hard time structuring your studying and you're just like, I just don't know what to do at this point, I'm more than happy if you want to send me some of your, like one of your most recent practice test score, and I can check and see with you, like, where are your weak areas, and then we can develop a strategy or a plan on, well, how should you gear your next week of studying, so that way if you take another practice test at the end of the week, we can hopefully see improvement happening in that either system content area, your section areas or if it's specific. Guys, stop. Go to bed. Hey, Blue, go to bed. Go to bed. Sorry, there is a tow truck backing up in my neighborhood right now. Oh yeah, I'd be more than happy to help you develop a strategy for studying over the next week or two or whatever, if you guys want that help. I don't charge anything for that. I just enjoy helping you guys out. So, okay, question number 8. Long-term management requires addressing sustained postural stressors. So, if you do A, manual therapy at each visit only, you're only going to give them short-term relief. They're only going to have relief for the amount of time they're seeing you and maybe the rest of that day, and then the very next day or the very next time they sit at their desk, it's going to come back very quickly. So A is not right. B, collars cause deconditioning. That could also be said about people that ask you, this drives me bananas, but people are always asking me about those braces that help pull your shoulders back to improve your posture. It might help in the short term, but they're forcing their body to rely on an external source of support, and so their brain is going to just say, oh, I don't even need these muscles to work anymore because the structure is doing it, and so it's going to get even weaker. And then C, daily cervical traction. It's not going to be preventative in terms of addressing their long-term symptom management, and so postural education and ergonomic modifications is going to be the best answer there. Number 9, a patient with shoulder instability anteriorly has no recent dislocations, but reports apprehension in abduction and external rotation. Which intervention is most appropriate? A, passive stretching into external rotation. B, joint mobilizations to increase external rotation. C, rotator cuff and scapular stabilizers. Or D, aggressive plyometric training immediately. Give you guys time to answer. I'm first year BSPT. Still don't know about. Can I send you mine because I'm a week out from my PTA exam? Yeah, Austin, absolutely. Austin, if you want, my internet was lagging, so it sent more than once. Oh, it's no big deal, user. Where are these questions sourced from? Therapy Ed? I actually write these questions myself, Julian. So I write these questions in advance. I give myself a week to prepare this stuff, and then I put it on here. So, but yeah, Austin, if you want to send me screenshots through DM, otherwise you can just DM me and I can give you my email. It's worked fine for a few people that I've talked with to just send me screenshots through my TikTok Messenger, and so that should be fine. Yeah, of course, Julian. Another thing, Julian, I will post, and everyone that's on here right now, I will post these probably tomorrow as a series of pictures as a TikTok video, so that way you guys will have these. So don't feel like you have to get them all tonight. I'll get them posted tomorrow, so that way you guys have access to them with the explanations. Okay, so it looks like most of you have answered. So dynamic stability is key for anterior instability, right? And so making sure that we're building up dynamic stability, which means muscle strengthening, right? Problem with anterior dislocations and anterior instability is that you don't have the static stability to keep your glenoid in the, or sorry, your humerus in the glenoid fossa. And so A and B, stretching or mobilizing into external rotation, is going to increase instability. I mean, that's literally the apprehension test, right? So stretching them into external rotation is either going to make them super apprehensive or you're going to pop their shoulder out of socket. So don't do that. And D, plyometrics is going to be too aggressive initially. They don't have great dynamic stability to support plyometrics. And so the answer should be C, rotator cuff strengthening and scapular stability. Number 10, this is our last MSK interventions question. I'm going to take a short break just to refill my water after that, and then we'll jump right into the neuro intervention questions. Carlos, good to have you. I don't know what you're saying yes to, but amen, brother. Number 10, a patient with acute cervical muscle strain 2 days post-injury presents with pain and guarding. Which intervention is most appropriate? A, prolonged immobilization. B, pain-free active range of motion and gentle soft tissue techniques. C, high velocity cervical manipulation. Or D, aggressive strengthening. You guys go ahead and answer. I'll read it one more time a little bit more slowly. A patient with acute cervical muscle strain 2 days post-injury presents with pain and guarding. Which intervention is most appropriate? A, prolonged immobilization. B, pain-free active range of motion and gentle soft tissue techniques. C, high velocity cervical manipulation. Or D, aggressive strengthening. I hope you guys can't hear my swallowing. This is not an ASMR video, and even if it was, it's pretty yucky to just listen to people swallowing. Perfume venter and Cassola joined. Chanel, what's up, girl? Welcome to NPTE Night School. So let's talk about the right answer. Oops. So in acute muscle strain, what we want to do is promote circulation and gentle motion, right? They're coming with pain and guarding, so we need to be focused this acutely on pain-free active range of motion and trying to decrease the guarding response. So if we can decrease pain, we'll decrease guarding response. So prolonged immobilization is actually going to delay recovery, and you're going to get substantial tightening down and stiffening of the injured muscle with prolonged immobilization. So then it's going to be an even harder recovery because you're going to have to focus so much more on soft tissue elongation and things like that, whereas you may have just needed to do active range of motion and they wouldn't have all that stiffness that built up. C, manipulation is contraindicated acutely. Can anyone tell me why? Number one, manipulation isn't helping the muscle, it's addressing a joint restriction potentially. And so, but can anyone tell me why manipulation is contraindicated this acutely? There's one key thing that I've already talked about in the stem of the question. Someone brave, otherwise I'm gonna start calling out people by name like mice. Is because it's still the acute stage. Yes, but what about the acute stage, and particularly what about how this patient is presenting? Guarding and pain. Guarding, exactly. So their muscles are already guarding, which means they're actively contracting, right? And so if I take them to end range and then do a high velocity thrust, what I'm probably going to do is strain the muscle that's guarding because I'm forcing it to stretch when it's really contracted, right? And so if you do a high velocity thrust on a joint where the surrounding muscles are guarding, you're more likely to just damage the muscles further. Number two, like I said, popping my neck isn't going to help my muscles. If I had capsular joint restriction, then sure, cervical manipulation might help increase range of motion in that regard, but the problem is an acute muscle strain. It's not a joint issue. And so if I do cervical manipulation, it's just going to hurt their muscles. So don't, in the event of acute muscle strain, be telling your patients, don't go to the chiropractor if what they want to do after your acute muscle strain is pop you. Bad idea. And then D, strengthening is too early. 2 days post-injury, you're not really, unless you're, and it doesn't say this, you could start by like strengthening the agonists, the synergists or the antagonists, but you wouldn't aggressively strengthen the muscle that was strained. And it doesn't say agonists or synergists or antagonists, right? It doesn't say aggressively strengthen antagonists or aggressively strengthen synergists. So don't add words to the question. You guys surely know that by now because you've been in PTA school for a while. There was one other thing I wanted to say about this. Oh, if something says aggressive or only, that's probably not the answer, right? Because it's trying to convey something that should be easy to eliminate. But don't get tricked, because let's go back up to this one. So there may be times, like this may have been easier to eliminate because I said upper trap strengthening only. But if I just said upper trapezius strengthening, you say scapular dyskinesis and shoulder bend during elevation. What does upward rotation? Upper traps. So you may look at that and be like, well, when it doesn't say only, it looks like a better answer choice. But just remember, clinically speaking, most of the time these peeps have overactive upper trapezius already, and what we need to do is strengthen the synergists. And so just keep in mind, I'll try to eliminate more of those answer choices only, so that it's a little bit harder maybe for you guys to narrow down between two, just to one. But okay, we are done with our MSK intervention questions. We are going to jump into neuro intervention, but I am going to take a quick 30-second break to fill my cup back up with water. And then we'll jump into neuro intervention. So give me 1 sec and I'll be right back. Okay, so let's go ahead and jump. Anyone here taking January MPTE? I'm sure it's funny because you guys, I won't share all your guys' info, but I do get you guys contacting me more regularly now, which I'm more than happy with because I actually really enjoy getting to discuss this stuff with you because I'm a huge nerd. But you guys should build some community here, and maybe you can do some studying, especially if you're not in PT school anymore. Maybe you can get some online studying done with some people. Okay, start with number 12. I told you we were going to skip number 11 because we did number 11 during the week in one of my TikTok videos. And so let's just jump right into number 12. A patient with hemiparetic gait demonstrates decreased push-off on the affected side. Which intervention is most appropriate? A, static standing balance training only. B, wheelchair mobility training. C, task-specific gait training with emphasis on propulsion, or D, passive stretching of plantar flexors. Trent, you have a question? Oh, no, you're saying you're taking the January boards. Never mind. I just saw the hand raise. I assumed the question, but no, I'm just dumb, that's all. Okay. All right, let's go over it. Motor learning is task specific. Practice the deficit. If you guys are going into neuro rehab as a profession, I was got to adjunct teach this last semester for the school that's right beneath the clinic that I work at, and it's always funny that making the transition because they're in a systems-based program, and so they learn all of their ortho year 1 and all of their neuro and cardio pulp in year 2. We're going over neuro rehab. And they're like, yeah, I just feel like I don't know what to do as an intervention because in ortho we had all this, stuff backlogged of like, how do you strengthen X, Y, or Z? And then in neuro rehab, they're like, I just don't know what to do. And I always tell students, what are they bad at? Do that. That's the intervention, right? And so remember, it's task specific. So A, static balance is not going to transfer to gait. B, wheelchair mobility training is going to avoid gait retraining. And D, stretching alone is going to be insufficient. So we're going to do task-specific gait training with emphasis on propulsion. Specifically, propulsion when they push off of that back foot, right? They get into that great toe extension and plantar flexion, and they want them to push off and land on the heel of that front foot. So the answer is C, like all of you said. Number 13. A patient post-stroke, exhibits severe spasticity of the elbow flexors, limiting functional use. Which intervention is most appropriate? A, quick stretch and tapping. B, prolonged stretching and weight bearing. C, maximal resistance strengthening. Or D, ballistic movements. But you guys have some time. Can I just take my boards with the chat? That's funny. I like it. So I live in Northwest Arkansas. And the closest testing center was in Fort Smith, which is like an hour and 15 minutes south of here. And I took it with like 7. It's a pretty small testing center. And it was like me, 7 of my classmates, and like 2 people from a different school that we didn't know. So it was pretty funny because it felt like we were all taking the test together, but obviously it's highly monitored. In fact, I had a different pair of glasses going into my boards exam, and on the nose pieces, there was like some ridges. And I walked out to take one of my breaks, and before I went back in, every single time I went back in, they made me take my glasses off, they put it on a plate, and they spun it to look for cameras or microphones or things like that. And they saw the ridges on my nose pieces, and they were like, are those speakers? Are those speakers right there? And I'm like, no, they're nose pieces to my glasses. I got pretty nervous when that happened. I was like, are you gonna kick me out of here for my ridged nose pieces right now? Okay, so number 13. The answer is B. Prolonged stretching and weight bearing. So sustained input through a joint is going to reduce tone and improve functional positioning. The reason that A is not effective, so if you were trying to elicit contraction, like if a person was flaccid, for instance, like if their muscles were flaccid, then quick stretch and tapping might help produce a muscular contraction, but it's actually going to worsen spasticity, because what we know about spasticity is it's velocity dependent. So if I suddenly quick stretch it, it's going to make spasticity worse, right? That's crazy. Yeah, dude. Don't be nervous about that though. Honestly, if you are not cheating and you know you're not cheating, you're not going to be pulled out of the thing. In fact, like I remember being like, can I even move? Like, can I do anything? And honestly, I got to the point where it's like, I'm just going to do my thing. If I need to move my wrist so that I can think of what the closed pack position is or whatever I was doing, I'm just going to do it. And if they flag it and then like email me or whatever, then I'll just tell them what I was doing. So the reason that C and D are wrong is because high resistance and ballistic movements are actually going to worsen tone. High resistance is going to cause tone to overreact, and so you're not going to get the movement that you want. And it's actually going to worsen the tone in any weight-bearing capacity for sure. Ballistic movements aren't just going to worsen the tone, it's going to activate that spasticity, because ballistic movements mean quick, and you're going to get that muscular contraction that you don't want. So, yeah, dude, boards, it's nerve-wracking because it's the most important test of your life, but it's really not. I think many of you will be surprised how you feel going out of that test, honestly. I walked out of there and I thought, I feel pretty good about that. So I also feel like I overstudied because I studied for like 16 weeks because that's what my classmates wanted to do. So, okay, a patient with a stroke demonstrates pusher syndrome. Which intervention is most appropriate? A, visual feedback using mirrors and vertical references. B, eyes closed balance training. C, vestibular habituation exercises. Or D, unilateral strengthening only. Give you guys some time to answer that. Okay, let's go over the answer. So pusher syndrome is impaired perception of verticality, right? And so if they have impaired perception of verticality, you need to use a sensory system that is adequately functioning in order to give them accurate input on what vertical is, right? So right off the bat, if you have them close their eyes, you just took away the sensory system that's going to give them accurate information about their verticality. If you remove their vision, their symptoms are going to worsen. It's an issue with their somatosensation, right? It's going to put them about 5 degrees off of center. And so B is a terrible idea. C, vestibular habituation exercises. That's not going to be helpful, again, because your vestibular system is one of the presumably accurately functioning sensory systems. And when you're doing vestibular habituation exercises, you're trying to occupy the vestibular system, making it less accurate to give your brain information about what upright feels like. And so that is a terrible idea, but also in pusher syndrome, vestibular treatment is not primary. And then D, strengthening isn't going to correct perception. While it may help improve the strength on their affected side, it's not going to change anything about their sensory perception of how they're oriented in space, right? So you need that visual feedback using mirrors and vertical references. So I will also put like a piece of tape or a plumb line or something down the middle of my mirror. So that way I try to get them to match up the direction that the tape is going. Number 15. A patient in the subacute stroke phase has impaired sitting balance. Which intervention best improves postural control? A, static sitting only, dynamic reaching tasks in sitting, passive trunk range of motion, or bed mobility training? All right, let's go ahead and go into the answer choices. So postural control improves with controlled challenges to center of mass. Improves with controlled challenges to center of mass. So the correct answer is B. You want to do dynamic reaching tasks so that you can challenge control of your center of mass over your base of support, right? So static sitting is not going to be sufficient because you're not challenging that postural control outside of your base of support with static sitting. Passive range of motion is not going to improve control because the muscles aren't having to activate. And bed mobility isn't going to target sitting balance. While it may help with trunk control, it's first off in a gravity independent position, if you want to call it that, so they're not having to hold their trunk up or anything. But we know that, like we said earlier, motor learning is task specific, so working on bed mobility is going to help their sitting balance. It doesn't transfer because it's not task specific. Number 16. Patient post-stroke presents with foot drop, not food drop. During swing phase, which intervention most directly improves gait safely? A, manual stretching of gastrocs. B, treadmill training without assistance. C, ankle foot orthosis. Or D, hip strengthening. Give you guys some more time. I'll read it a little bit more slowly this time. Postural control improves with oh my gosh, I'm so stupid. A patient post-stroke presents with foot drop during swing phase. Which intervention most directly improves gait safety? A, manual stretching of gastroc. B, treadmill training without assistance. C, ankle foot orthosis. Or D, hip strengthening. Okay, let's go ahead and go over the answers. So, the answer is C, because it's going to provide immediate foot clearance and safety during gait. Stretching gastroc isn't going to help with swing phase, so there might have tight gastrocs, but if the problem, let's say, it's foot drop, so we're assuming it's related to strength of their dorsiflexors, right? So stretching their gastroc isn't going to help them be able to lift their foot as a result of weakness during swing phase. B, I would love to do treadmill training with this patient, but realistically, they're probably going to need assistance. It would be very unsafe for me to put them on a treadmill. And remember, this doesn't say bodyweight supported treadmill training, it says treadmill training. So I can't even assume that they're harnessed in or have any way of keeping themselves safe. So while I would love to do treadmill training with them, without assistance is totally unsafe, so I can't do that. And D, proximal strength alone is not going to be sufficient for helping their foot drop, right? So providing an ankle foot orthosis is going to be the best option there. 17. A patient with stroke demonstrates ataxia of the upper extremity. Which intervention is most appropriate? A, fast ballistic movements. B, weighted extremity activities for stability. C, high repetition passive range of motion. Or D, maximal resistance training. Give you guys just a little bit more time to look it over. And if you guys have classmates or friends or family or whoever that is studying for their boards in the next several months, even if they're not taking it in January, 3 months away, there's another one in April and then another 3 months. It'll be taking one in July, so I'm going to be doing this as regularly as possible. If you have underclassmen or people below you in school that just need something consistent to try to help them interact with NPTE practice questions, the entire South College is here. User! That's because you're like one of my most consistent fans here, along with like Trent and Northgate, Nightmare and Labs. Chanel is here consistently. There's another one named Fibula that comes pretty consistently. This is only number 5. I got it wrong earlier. I thought this was number 6, but this is just number 5. But if you guys know people that want this kind of free access to as a resource, then please. I was like, yeah, you're on the giant post-it notes. DBT roll caller from UNF. Okay. Oh, Raid. I am terrible with geography and flags from different countries, so you're going to be ashamed that I don't know what country that flag represents. I'm sorry. Anyway, I want to be helpful to you guys as much as possible. Filipino, thank you. Thank you. You know, I've had several people from the Philippines join, which is kind of wild. I don't know what the time difference is, but I would feel like this would be an odd time of day for you guys. But maybe not. Maybe it's perfect time. Okay, let's talk about the answer to this question. So, weight can dampen a tremor and improve control of ataxia. So the answer is B. If you weight their extremity, it can help improve the stability because it can dampen their tremor and allow them to have greater control as the limb elongates away from their body. Ballistic movements are going to worsen dysmetria because these people are ataxic, so they have poor coordination. If you try to make them do it fast, it's a good time here. It's going to be 11 a.m. son. Oh, dope. Yeah, honestly, I picked 8 p.m. because I had a group of people in the first... What's NPTE? The National Physical Therapy Examination. That's what NPTE is. I had a group of people that told me they thought Sundays would work best in the evening. And I can only do 8 o'clock on Sundays because my daughter goes to bed at like 7:30. And it's not... 8 p.m. isn't too late that anyone on the eastern side of the world is going to miss out. Eastern side of the world. Eastern side of the U.S. is what I meant to say. Okay. Passive range of motion is going to be ineffective. Now, here's where I would say high repetition active range of motion would not be a bad choice. Passive range of motion, they're not having to activate muscles at all, so they're not actually producing any motor learning, even though you're doing high repetitions. But we know that with ataxia generally means that they've got a cerebellar infarct, right? NCS is neurological clinical specialty. And so a specific section of the American Physical Therapy Association, it's called the American Board of Physical Therapy Specialties, has different specialties that you can get. SPTA here, but still very helpful. Good. They have different specialties that you can get depending on what kind of setting you work in. So I have gotten many hours over the last 3.5 years in neuro rehab, and I knew that I wanted to specialize in neuro rehab when I got to school. And so I got the required hours I needed in the neuro setting so that way I could apply to sit for the NCS and the NCS exam. And now I have my clinical specialty in neurologic physical therapy. So, but they have OCS, orthopedics, they have pediatrics. I am in the outpatient neuro setting. So I usually get the people who have just come out of inpatient rehab or the people with chronic deficits. So I frequently see people over the course of time for a long time. So I get my Parkinson's patients come back over the course of years, right, just for like tune-ups. My stroke patients who haven't, let's say that we've maximized their recovery and then they come back because as they get older, they're going to have more likelihood of falling, then we work on again. So yeah, I don't even remember where I was. Oh, high repetition active range of motion could be good because if it was a cerebellar infarct causing the ataxia, then high repetition active range of motion is going to be helpful. If it was more task specific, then it would not just active range of motion, that would be great, but it's passive range of motion, so that's why that is a bad choice. And then if you use maximal resistance strengthening, it's going to reduce coordination because they're having to contract with higher levels of force, and so the coordination is going to be impaired. Would have I worked in a neuro inpatient rehab facility? So I had 2 of my clinical rotations at really intense inpatient rehab facilities. So my first one was Methodist Rehabilitation Center in Jackson, Mississippi. And my second one was TIER Memorial Hermann in Houston, Texas. And I absolutely loved the inpatient rehab facilities or the inpatient rehab setting. I live in Northwest Arkansas, and we have like two. My DPT was 3 years after my bachelor's degree. So it was 7 years total of school after high school. So Derek, I would have worked in inpatient rehab, but we don't have any like substantial neuro inpatient rehab facilities here in Northwest Arkansas. And I wanted to specifically focus on just the neuro population. I didn't want to have to treat a bunch of post-op hips, a bunch of post-op knees, and all that stuff. So there was a clinic that needed an outpatient neurotherapist, and I took it. I worked there for about 1.5 years, and now I'm in a different role, or I'm in a neuro rehab role in an outpatient clinic somewhere else, which is actually closer to where I live. Number 18, a patient post-stroke demonstrates poor motor planning, also known as apraxia. Which intervention is most appropriate? A, random practice with minimal cues. B, high-speed gait training. C, strength training only. Or D, task breakdown with verbal and visual cues. I'm going to read it one more time, a little more slowly. A patient post-stroke demonstrates poor motor planning, apraxia. Which intervention is most appropriate? A, random practice with minimal cues. B, high-speed gait training. C, strength training only. Or D, task breakdown with verbal and visual cues. I think you'll like it. Do you know where it's at, Derek? Trent, D, but A looks tempting. Yeah. Good. When I made one where you were second guessing. So let's just go ahead and go over this answer. So apraxia is impaired motor planning. Impaired motor planning. So if you have them do random practice, they have problems with their motor planning, so they're going to do a really random job. So random practice with minimal cues is not going to be effective in trying to treat a person's apraxia. We need structured cueing, and so like structured regular cueing initially. Random practice is going to be too advanced. Speed training is inappropriate in a person with apraxia because, again, it's poor motor planning. If you are trying to maximize speed, they're going to have even worse motor control. Is it true that 6 months is the golden time for stroke recovery? I'll talk about that here in just a second. C, strength isn't the limiting factor, so that's why C is not right. Strength isn't an issue of their apraxia, it's motor planning is the problem. So when would random practice be good with min cues? Dementia, so perhaps dementia, but the thing with dementia is you want it to be structured still, so the best, what research says is the best approach to try to maximize recovery, like functional recovery in dementia, is the same structure every single time. So like if a person comes in and sees me, we're gonna start off with like a warm up on the bike or the treadmill, and then we're gonna work on sit to stands every single time, right? This is just an example for motor learning goals, right? Yeah. So, random practice would be good with like post-stroke patients, right? It would be good with, I mean, in general, motor learning. So your SCI, your TBI patients, it's just with people with apraxia particularly and cerebellar deficits. You want to try to promote errorless learning. So you really want to maximize quality repetitions and then be able to recreate it every single time. And so random practice could be good with dementia, but you want it to be within the same framework of what you've lined out for their sessions, because consistency is going to be best for our patients with dementia. So if I always do walking to start, and then I always do sit to stand, and then I always do like a balance activity or something like that, and then I always do whatever, making sure that it's in the 1, 2, 3, 4, 5 steps order. Is it true that 6 months is the golden time for stroke recovery? So 6 months is where they're going to get the most spontaneous recovery back. Meaning that like if we didn't intervene at all, if there was no rehab, then the majority of their spontaneous recovery as a result of their nervous system just healing is going to be basically over by 6 months. But that doesn't mean change can't occur. In fact, everything that we're seeing in our neuro rehab literature is suggesting that with concerted effort and utilizing the right principles of motor learning, they can continue to improve. Now, there are some deficits that can be permanent, right? So like foot drop might be a permanent limitation that they have forever. And so we need to make sure that we're maximizing their functional potential by utilizing assistive devices in that regard. So 6 months, I wouldn't say it's the golden time frame for stroke recovery, but we know we need to get them moving early, just as a general rule of thumb for any human being after an injury. Number 2, if we can push their aerobic capacity, we can help stimulate those brain-derived neurotropic factors, which are going to help maximize brain recovery. We know that utilizing exercise in that 6-month time frame can really help promote neural recovery, but they can continue to make changes beyond the 6-month time frame. A lot of patients will get really discouraged because they're told after 6 months you've got what you got, but that's not entirely true. Some stuff can be permanent though. Is there the diagnosis for random practice? I don't remember. Okay, so generally in motor learning for adults, the best approach is going to be random practice, okay? Now, specific neurologic diagnoses like apraxia, and hold on, I gotta update this so that way they don't kick me off of my live. Okay. Apraxia and cerebellar infarcts aren't going to improve with random practice because you have the impaired motor control, right, with apraxia, and with ataxia or cerebellar infarcts, you have no comparator to tell your cerebrum or the cortex that there was error in the movement. And so SCI generally, stroke generally, unless it's specific to apraxia or cerebellar infarcts, TBI, MS, random practice is going to be best. Any of your balance disorders, vestibular stuff, random practice is going to be best. There's not like a pinpoint diagnosis specifically, but in adults, for neuro recovery and motor learning, random practice is generally the best answer. The difference between ideational and ideomotor apraxia is gosh, you have to ask this, don't you? Okay, so ideational apraxia is like so ideomotor apraxia is you can't remember, like if I tell you, show me how you would brush your teeth, you can't remember how you would do it, and so maybe you like start stroking your hand or stroking your hair, like, I don't know, taking your glasses off. But if I gave you a toothbrush, you would know automatically how you use a toothbrush, right? Ideational apraxia would be like, I have no idea how to use this thing. So even if it's in my hand, it's not automatic. I haven't looked over this concept in a year or two, so I'm pretty confident that's the difference though. I've heard EDS is a neuro disorder, but I don't understand how. Yes, you're welcome. Hypermobile EDS is a neuro disorder, but I don't understand how. Okay, so there's neurologic components, because in hypermobile, by the way, when do you do this TikTok live? I want to join regularly. So I do it Sunday evenings at 8 p.m. Central Standard Time here in the United States, every Sunday evening, okay? Sorry, I'm getting Emma. Hypermobile EDS can be a neurologic disorder, although there can be a lot of other systemic issues going on. A lot of people will have difficulty, or they will complain of having a lot of clumsiness, and it's because they're hypermobile. Their joint receptors and their muscle spindles, don't give them accurate proprioception, and so because they have inaccurate proprioception, that can lead to that clumsiness. And so we really have to maximize other sensory inputs to try to help improve their proprioceptive awareness, so that way they know how their bodies are moving through space. That's how I would say there's a neurologic component to hypermobile EDS syndrome. I'm just talking and talking. You guys got to keep me on track. I'm so sorry. I feel like I might have an attention disorder. Okay, number 19. A patient in inpatient rehab following a stroke fatigues quickly during therapy, which intervention strategy is most appropriate? A, one long continuous session. B, passive modalities only. C, distributed practice with rest breaks. Or D, high intensity training regardless of fatigue. You guys know your ish. You guys know. Let's go ahead and go over the answer. The answer is C. Distributed practice with rest breaks is going to improve motor learning while managing central fatigue. A is a bad idea because continuous practice will lead to movement deterioration, and so it's not going to help promote the best recovery. B is a bad answer because passive modalities don't promote recovery whatsoever. And D, ignoring fatigue reduces performance and their motor learning. And so ignoring fatigue is actually going to be detrimental to their recovery. I can only answer questions on TikTok Live, apparently. Hey, man, that's okay. Contact FSBPT and ask them if they'll let me proctor your exam or something. I'm kidding. Put a Pete in front of me and I blank. Oh, you guys can do it. You chose C as an answer, but you don't understand. Okay, so you're distributing practice. So you're not making them practice a bunch of stuff for an extended period of time, right? You're distributing it. So like we're going to work on walking for 10 minutes, then we're going to take a rest break so that way we can try to minimize the fatigue, right? And then we're going to distribute practice again, right? And so we're picking, let's say we'll pick a deficit, we'll do distributed practices for short durations, give them rest breaks, and then do it again. Because if we can minimize the fatigue response and help them recover with rest breaks, then we're going to help promote learning better. If you user 8670743702563, if you're asking me where I did my DPT, I did mine at the University of Arkansas for Medical Sciences here in Fayetteville, Arkansas. Should I take my second PET tomorrow? Austin, I think you told, well, you said your test is like next week, right? So I think that would be fine. I think that'd be fine. And it'll kind of give you an idea of where you're at before you take your test. And it'll also give you an idea, it'll also give you an idea of what kind of areas you need to clean up over the course of the next week before your boards on, I think you said the 7th, right? Is that a Wednesday? I think you said the 7th, but I'm not 100% sure. Okay. One more question, and then we can talk about other stuff if you guys want. A patient post-stroke demonstrates neglect of the affected side. Which intervention is most appropriate? Visual scanning training toward the affected side. B, positioning stimuli on the non-affected side. C, eyes closed balance activities. D, passive range of motion only. Are we able to rewatch your lives? No, you aren't. You aren't, Pedro. So what I would say is, so I'm going to post all these questions, Pedro, probably tomorrow. And so you'll have access to the questions because I'll post a TikTok that you can just scroll through the questions, and I'll have the answer choices up there so that way you can see what the stuff was and the explanations. You got a 50% on my practice exam using Final Frontier. Should I be concerned? That's a good question, Mickey. If you haven't taken an FSBPT PET exam, I would highly recommend you buy those. They cost like $50. You can buy a separate set than what your school paid for if your school did provide a couple for you. If you get higher than a 600, if you get a 600 or higher on the PET, that is the best indicator that you are, statistically it's the best indicator that you have a higher likelihood of passing your boards. I will totally be honest with you, when I took my 2 Final Frontier exams, those were the hardest tests of all the practice tests I took. And I scored the lowest on my first Final Frontier exam. But what I will say is like it really illuminated where I was lacking, even though it went into some stuff like unilateral vestibular hypofunction, which you are not going to be tested on your boards. You will not be tested on UVH. You will be when it comes to the vestibular system, you will be tested on BPPV, and what I mean by that is posterior canal, BPPV, probably canalolithiasis, not cupulolithiasis, and maybe they want you to be able to distinguish when something is a central nervous system problem as opposed to a peripheral vestibular system problem. And what I mean is they're going to be like, patient complains of dizziness. Upon examination, you know vertical nystagmus that is not minimized with gaze fixation. And it's basically the answer is going to be refer out, send them to the emergency room, something like that. So that being said, those final frontier exams are freaking hard, number one. Number two, I would say take a PEAT. If you buy the PEAT, you're going to get a practice form and an actual retired NPTE. If you take that and both of them are showing that you got passing scores on that, that's the best indicator of success on the NPTE. Okay, I taken in April last week, scored 550 out of 800, 64% on around, 11 questions off from on track to pass. Yes, I absolutely think you have enough time though, 100%. You still have like 12 weeks, so you have plenty of time. Okay, so the answer is A. Visual scanning toward the affected side is going to directly retrain attention to the neglected hemispace. B is going to reinforce neglect because you're putting stimuli on the non-affected side. They're already maintaining gaze at midline or over to the non-affected side. And so it's just going to reinforce the neglect. C, if you make them close their eyes and try to balance, it's all like vision removal is also going to worsen their neglect. And passive range of motion doesn't address attention. So, all right. Like I said, I will get screenshots of these and I will post these as a video on TikTok. Is it helpful to position stimuli in affected side for patients with neglect? 100%. Yes, it is helpful to position stimuli on the affected side for patients with neglect, but you're probably gonna have to do a lot of cueing to get them to attend to the neglected side. He's answering the question now. Oops. Okay. Yep, we'll be using Final Frontier. Okay, so do you guys have any questions about tips or any questions about the stuff we went over? Trent, I was thinking about it while we were going over one of these questions. Honestly, if you guys are struggling more when you get the test in front of you, the reason this might be easier is because I'm actually reading the questions out loud, which means I'm minimizing the opportunity for you to misread the question, right? And sometimes the issue is, like, one thing I had to really focus on was not reading my questions too fast, so that way I didn't misread a word in the question, right? And so make sure you're taking your time reading over the questions, read it multiple times if you need to, and read over the answer choices multiple times. Make sure you're not reading too quickly. So when I read it out loud to you guys are reading it and I'm reading it out loud, so it minimizes the opportunity to misread something, right? The other thing is, you're right, you're gonna feel like things are higher stakes when you're taking a practice exam. So one of the biggest things I am an advocate for, and I did this and I did really well on my NPTE. So, and I think it's because of how I prepared myself. So I would practice. Yeah, the taking timer makes it feel like I have to go faster. Keep in mind, think about how much time you're taking up when you're taking those practice tests, right? So let me tell you what my strategy became. I had the 2 PEATs that my school provided. I took one in March or beginning of April when I got back from my last rotation. I had to take another one in May before I could graduate, and I had to pass it. I had 3 score builders tests, so I'm already at 5 practice tests, right? I had 2 Final Frontier exams, and then I bought 2 more PEATs, or 1 more PEAT, which had 2 more tests with it. So I took 9 practice exams, okay? That's a lot of practice exams. And the way I studied over the course of the 16 weeks, I didn't take a practice exam every week because I wouldn't be able to, right, over 16 weeks, but I dispersed them a little bit more widely, so that way I could like really hyper focus in those time periods on a lot more content. But as I really started to hone in and improve some content areas, I didn't need to study those as much, and so I could wean up, I guess, taking practice exams more quickly. So what I would do is I'd take an exam on like a Thursday morning, and my NPTE was scheduled for 8 a.m. on a Tuesday or something like that. On test days, I would have increased anxiety. I'd have to go to the bathroom more. So I never drank coffee on test days because I was worried it was just going to give me bubble guts and make me even more nervous. So when I would take my practice exams, I took them at 8 a.m. and I never drank coffee, right? And then when I was taking practice exams, this happened all the way through PT school. I finished every test early because what I do is I answer a question and I move on. I never look back. After I've selected an answer, I never look back. I personally don't flag questions because if I go back to it, I'm going to second guess myself. So I answer it. If it's a question that I'm struggling with, I will stay on that page until I answer it. And if I'm starting to run out of time, then I'll just give my best guess and I'll move on, okay? So I was finishing my practice tests with plenty of time. Like, you get 5 hours, and I think I was finishing it in like 2.5 to 3, right? So I decided I'm gonna take the full 15 minutes after section 2, I think it is, but I don't remember anymore. So then I decided after section 1, I was gonna take a 5-minute break. And so I did. So every practice exam, I practiced taking a 5-minute break after section 1, took a 15-minute break after section 2, 5-minute break after section 3, and then I gave myself another 15-minute break after section 4 because I was always finishing with plenty of time, and then I would take section 5 and then I would leave, right? So when I would take my practice exams, I did it the same way every single time to try to emulate what I expected my test to be like on my NPTE test date. I don't think the real exam is way harder than the PET. And let me tell you why. When I took my first PET, I had not studied, right? So I had 3 years of information, some stuff I hadn't looked at since year 1 of PT school, right? And then I took my PET, and my first one, my practice form. And I had a pretty good baseline score, but it was the least amount of information, or I hadn't studied in forever, right? So then I studied my butt off and took it again in May and passed to graduate. And then by the time I took my boards at the end of July, I studied for 16 weeks. I way overstudied. By the time I took my boards at the end of July, I walked out of that room feeling like, yeah, I'm good. I feel really good about that. I had a buddy call me after, and he said, how do you feel about it? And I said, I feel pretty good. And he said, I feel pretty good. He was one of my buddies that I studied with for 16 weeks. So the reason I didn't think that the NPTE was harder than the PET is because I felt like I had really prepared myself for that NPTE. But you're probably right. If people say that, it's probably because they're feeling a lot more test day nerves. Trent, the whole reason I even brought that up is because if you are taking your tests and you're like, I consistently have 30 to 45 minutes, if it helps you to take short breaks in between sections just to try to calm your nerves, or just get up and go to the bathroom, or get up and walk around, or pace, or whatever, I honestly think taking those breaks dispersed like that really helped with my testing fatigue. And the more I practiced, because I took 9 of these practice exams, I got to build up my cognitive endurance, my mental endurance. So that way, I want to say section 3 or section 4 was my worst one, but I still did really well on it. And so I think it's important that you guys if you like my advice and you want to take it, go for it. I'm not telling you have to do what I did to take the boards or to be able to pass the boards, but I know how I study effectively and I know how I learn stuff. And so I just did what I knew what to do for me to be able to learn that stuff effectively. And then I ended up, I'm not trying to be braggy, but I'll just tell you, I studied for 16 weeks. I tell you I overstudied because all I needed to be Dr. Miller was a 600, and I ended up getting a 795 because I way overprepared. But I prepared myself in a way that I knew I needed in order to do as best as I possibly could. Hi, Morgan. I don't know if I know you, but hi, dude. Okay. If you guys have any other questions for me right now, I'll stay on for a little bit longer. If you guys come up with questions throughout the week before our next NPTE night school, then you can just direct message me, or you can comment on one of my videos, and I'd be happy to talk you through anything. Yeah, of course, Trent. Thanks for joining again, my friend. I would not mind throwing in some gate-focused questions. Do you mean specifically gate assessment, talking about normal gate pattern or abnormal gate patterns and things like that, or interventions for gates? Yeah, I'd be happy to do that. Another thing I need to do is non-systems, and I said I would do some other systems, but then Austin said he, was it Austin or user? Pharmacology. I'll do some pharmacology too. Deficits and interventions for sure. Let's do some endocrine questions and whatnot. Okay, I'll start making a list of what we need to do. I need to try to be better about posting throughout the week so that way we can knock some of this stuff out during the week too. I'm gonna send you my Pete score now. Sure, Austin. That's the other thing I wanted to tell you guys. If you want, if you think that what I do is helpful and you want some tips, if you just need maybe an unbiased set of eyes to look, I'd be more than happy to just talk through what would be a good strategy for you to develop, regardless of when your your NPTE is. If you're taking it in January, we can talk about how should we structure your studying over the course of the next month to maximize your score in the January. If you're not taking it until April or July, then we can build up a strategy of like, when should you start studying? What should you start with? All of that stuff, okay? All right, I need to write this down. Pharmacology, gate deviations and interventions, endocrine, non-systems, and I said I wanted to get to other systems too. So I'll make a list and I'll start coming up with some questions throughout the week as well. Yeah, so if you guys want that help from me, just to help sort of develop your studying, regardless of when your NPTE is, if you have test scores you want to send me, like practice test scores you want to send me so I can kind of see how you're scoring in different sections and in different content areas, I'd be happy to look at those and then tell you what I think I would do if I was the one scoring like that and how I would gear my studying. But yeah, I'm kind of just rambling now, but just use me as a resource because I'm not going to charge you guys for it, and I just want to help as much as possible because I want you guys to be successful. It helps our profession if you guys are successful clinicians, right? And you can't be a successful clinician if you're not a licensed clinician. So, all right, I will be here again next Sunday at 8 p.m. Central Standard Time here in the U.S. Contact me if you need anything from me throughout the week before Sunday. And other than that, have a good week. Happy New Year's to you all. I hope you all had a good Christmas, and I will see you next week. Bye, guys.